Diagnosis. In these cystoscopic days, when every obscure case of bladder or renal infection submits to cystoscopy and radiography, one is not surprised occasionally to find an unlooked-for bladder stone. Stone is suspected when the previously related symptoms are found. If the bladder is much inflamed, the cystoscope may not readily distinguish a stone from a sloughy tumor or from a tumor encrusted with phosphates. If there is any doubt, the cystoscope may be used as a searcher to tap against the stone. The sensation imparted distinguishes the solid stone. Large stones can be readily diagnosed by tapping with almost any urethral instrument excepting a soft rubber catheter. Even the woven catheter will strike its end against the stone and give the characteristic impact. Small stones, on the other hand, are very elusive and are not found readily by the old-fashioned searcher, while the encysted stone and the stone behind the prostate elude this as well. For these reasons, the stone searcher has quite fallen into disrepute and has been replaced by the cystoscope. The presence of bladder stone leads to the suspicion of renal stone. This should be proven by X-ray and renal function test. Prognosis. Unless the stone is small enough to be viable through the urethra, there is only one prognosis. It will certainly remain, and the symptoms will inevitably grow more severe until it is removed by operation. Treatment. The treatment of stone in the bladder is operative. The choice of operation depends in some measure upon the patient's condition, in some measure upon the surgeon's skill. The surgeon may choose between 3 operations: lethallopaxy, suprapubic, and perineal lithotomy. The performance of lethallopaxy requires a training and an opportunity for performing the operation with relative frequency, which few, even among specialists, can command. Lethallopaxy is the operation of choice at the hands of a skilled operator for all uncomplicated and relatively small cases of stone in the bladder. Each surgeon must decide for himself what type of case he considers suitable for the operation. In India, where bladder stones are extremely frequent among young people, lethallopaxy is preferred above all other operations, even for large stones. In this country, where stones are relatively few and usually due to retention of urine, many specialists do not perform lethallopaxy at all. I prefer the operation in adults for uncomplicated stone up to about a diameter of 4 centimeters. Suprapubic lithotomy is the operation of choice for large stones, for children, for stones the result of prostatism, or other pathological conditions about the bladder requiring operation. Its mortality is slightly greater, its convalescence slightly longer than lethallopaxy. I have never lost a patient after lethallopaxy, though I have several times had to repeat the operation on account of fragments left behind at the first crushing. Perineal lithotomy is the operation of choice when some condition in the urethra, such as stricture, requires a perineal section. The mortality of operations upon large bladder stones is extremely high because these cases invariably have a gravely impaired renal function through chronic renal infection. Preliminary examination by phenylsulfonephthalene discloses this condition and indicates the necessity for great care in the selection of an anesthetic. Generally speaking, such cases should be operated upon by suprapubic lithotomy under a local anesthetic.